I'm going to talk to you today about what cybersecurity can teach us about testing for COVID-19. This work was done in collaboration with Dr. Lior Cohen from Course AI, with Professor Bracha Shapira, Professor Jacob Moran-Gilad, and Professor Lior Rokach from Ben-Gurion University. And it's a part of my thesis work for PhD. So imagine that you're a doctor and you have a waiting room filled with patients and you only have one swab left. Who would you test for COVID-19? This question is relevant and asked here because testing is bounded. It's bounded by the number of available tests, bounded by reagent, bottlenecks, and for many other technical domains. Let me ask you again, if you were a doctor and those were your patients, who would you test for COVID-19? On the right upper corner, we have a patient at his 70s. He's suffering from diarrhea and from cold, and he has a cold. If he has COVID-19, early detection could mean that we're going to treat him better and we're going to improve his survival rates. On the bottom right corner, we have a patient at his 30s. He has high fever, he's coughing, and he's suffering from muscle aches. So he has a high probability of testing positive for COVID-19. Early detection of him or positive test result means that we can start a contact tracing and we can trace all the people that he has been in contact with recently and maybe stop the spreading of the virus. So our answer to this question depends on our priorities, on what we would like to achieve by testing for COVID-19. So why are we testing for COVID-19? We are testing for COVID-19 because we would like to identify sick individuals in order to treat them correctly and safely. We also would like to stop the disease from spreading by contact tracing of positive individuals. But we also have a third goal. We would like to provide accurate data for government decision making. For example, the government would like to know if there is a need for a lockdown, or maybe if we're already in a lockdown, can we get out of the lockdown? How fast can we get out of the lockdown, etc. So we did this research during April when Israel was at the peak of her first wave of COVID-19. And at that time, there was little known about how the virus behaves, how the virus spreads. And you know, each country had a different testing policy. Most of them were unofficial, so it was really hard to compare between countries, what is the situation. And there were huge differences, as I said, because Italy, for example, tested only people that were in hospitals. And Sweden tested the worst cases and all the dead people. And in Israel, we tested with a policy. You had to have a few symptoms or to be in contact with a confirmed case. And we also had some exploration. And in Wuhan, they were planning on testing everyone, that is 11 million people. So the testing policy can really differ between the countries. Most of these countries, we're not talking about Wuhan, who had no limitations, had a restricted capacity of tests. So they implemented a risk-driven policy. The problem with the risk-driven policy is that the result is very biased towards the policy. That is, if we're testing only people with symptoms, then we're most likely not to see patients that are asymptomatic. And the policy can also really determine the results, because if at the beginning, in April, when they were testing only hospitals, it makes it look 10 times as deadly as it is. This bias has two major problems. The first one is that the decision makers, they don't get accurate and wide information that they need for decision making. And also, we are missing our ability of early identification of clusters, of new clusters, because we are busy on testing what we already know that is more likely to be positive. This phenomena of being trapped in a subspace of options and thereby losing our ability to explore beyond what we already know, is very well known in recommender systems, like in Netflix. If you're watching 2 days in a row a Christmas movie, then at the third day you're more likely to get all of your feed filled with Christmas movies. Sorry, Netflix, I really like you. This phenomenon is called the filter bubble. And we really need to know that we have this problem in order to deal with it. So what I'm talking about today, the problem that we can't really test all the people, all the population, and we can only look at a sample, is a sampling problem. But why are we testing? What would we like to achieve? We would like to discover as many positive cases, if not all of them, for treatment and for contact tracing, as we discussed before. But we would also want to learn about the nature of the spread of the virus. Is the sample group representative enough? Just like in the elections. So we have two goals, and we have to keep it in mind in order to do our sampling right. This challenge of monitoring the population with the limited capacity is not unique for epidemiology, and it's actually applied in many domains. Since this is a problem of balancing exploitation, the need to maximize the detection of many, if not all, infected people, with exploration, the need to learn more about the nature of the spread, then a mob is a perfect fit. It's like really natural that it comes to mind. I originally started my PhD work in the domain of the cybersecurity monitoring, and especially in monitoring database activity monitoring. So what does database activity monitoring looks like? We have hundreds of thousands of transactions per second, that go in through the system. We cannot really save them all because it's a huge amount of data. So we are logging only a subset of the data, and this data that is logged and saved is fed into the anomaly detection system, which our goal is to detect the risks and the risky events. What is a logging policy? Since we can't save all the transactions, as I told you, we are only saving a fraction. Which fraction should we save? Well, that is decided by the regulation, telling us what data should be saved and for how long, and by the security officer that defines the hazards and the risk in the domain. And how is it done? It's done manual. It's a manual job there, so it's basically rule-based scenario, a policy. The policy is basically rule-based. What are the problems in the cybersecurity domain? The problem is, and not only in the cybersecurity domain, it's also very similar in our problem. Problem is that the policy shapes what it captures, therefore creating a filter bubble. And since we're only capturing the risky activity, therefore the security officer doesn't really know what the normal activity looks like. So our data is really biased and skewed. For example, in the COVID-19 problem, the initial estimate of COVID-19 mortality were really skewed and really high because we were testing only people in hospitals and only dead bodies. And since we are so skewed and we're trapped in a filter bubble, then it's really hard to identify new types of risk, or in the COVID-19 problem, new clusters. So we would like to move to make a shift from a static policy to a dynamic policy that really learns the material and keeps searching for new risk and learning how what to monitor. So why are cybersecurity risk monitoring and COVID-19 testing similar? Because in both problems we have a capacity that is limited, and in both problems the individuals and the features can change their risk profile during their life cycle. So the probability of me testing positive for COVID-19 today may change drastically if the people in my area are infected with COVID-19 than it was 5 weeks ago when there were no infections around me. And both problems monitoring had two similar goals. We would like to maximize the detected infected individuals, and we would like to maximize the knowledge about the spread of for decision making. So now that we define the problem in terms of exploration and exploitation, it's only natural that we seek for a solution in the set of problems that are called multi-armed bandits. For those of you who are unfamiliar with it, let me tell you a little bit about it. So this is a set of problems that come from the domain of playing the slot machine. So imagine that you're in the room of the slot machine in Las Vegas, and you have a bucket of coins in your hand, and you have to decide which machine to play. So if you're just sitting at the first machine that you found in the room, then maybe there is a better machine or many other better machines in the room that you're not playing with. But if you keep hopping between machines, then maybe someone else is winning at this time at the machine with the really high reward that you found before. So this need to balance between exploration and exploitation is well explored within this problem. And there are very good solutions for this problem that are proposed. So how is it relevant to our problem, and how is it implemented? As I said before, in the database activity monitoring, our goal was to find the optimal strategy for sampling users in the database activity using the available resources in order to maximize the monitored risky activity. So this is a sub-problem, a new problem, novel problem, that we define within the domain of multi-armed bandit, where we have a capacity at each time frame. Instead of playing only one slot machine, we are pulling a few arms. How many arms depend on our available resources. And also, in the slot machine, the reward probability is static, but in our problem, the reward probability may change during the user's life cycle. As I said before, the probability of an individual to test positive may change drastically between days and weeks, depending on the general condition. So I'm taking my inspiration from the cybersecurity domain. How is it done in the cybersecurity domain? How do we implement monitoring? How did I implement monitoring? Well, I created a risk score per event, and I ranked these events in a descending order, and investigated the top events. Why only the top events? Because our capacity is limited. I will show you that we can implement the same approach for the coronavirus monitoring problem. Now I will describe how to implement the capacity epsilon greedy algorithm that I suggest to solve this problem. So we're working in time frames. Every time frame, we're defining the policy for the next, at the beginning of each time frame, we're defining the policy that we'll be implementing during the time frame. At the end of each time frame, we're rethinking and relearning and so on. So at the beginning of the time frame, we would create a rank for all the candidates using the risk score. We would sample 70% of the capacity using the most risky approach. And we are randomly sampling the rest, that is 30% of the capacity. At the end of the time frame, we would update the risk scoring model based on the results of the previous time frames. The epsilon greedy algorithm stands for the proportion of the capacity invested in exploration. So in our case, it's 30%. So at the beginning of April, when I was working on it, I was just like, cooking this idea in my mind. I was asking myself, well, I have this great idea, right, of balancing exploration and exploitation. I really understand all the problems what is wrong with the way that we are testing today. But this thing that I want to suggest, can we implement it for COVID-19 testing? Can potential candidates for testing for COVID-19 be ranked? Who should we test first? So to show the feasibility of my idea, first I have to show that we can rank all these cases. And for that, we use the data set published by the Israeli Ministry of Health Data, the testing data set. If you're interested about the data set, we can talk about it later. And we did the data exploration like any data scientist would do, and we saw that the contact with positive patients, cough and fever, were the strongest features. So we decided to compare three different ranking methods. The first one was the baseline, the rule-based one, which we used these high correlated features, and we scored them with weights. Contact with positive patient got 2 points, cough got 1 point, fever got 1 point, and all the candidates got their scores and were ranked accordingly. We also used the linear SVM classifier and a polynomial SVM classifier. It was a polynomial from the second degree because we assumed that there were relations between two features that could be learned, but we didn't really want to overfit. The really interesting question is how to evaluate the results of our classifiers. So we're not really interested in classifying because we only want to rank the results. So we don't really care about the general F measure. Since we are using the ranking to decide who to test first and using the most risky approach, what's important for us is the measure that is called recall at N, because we would like to know if our ranking is effective given a certain capacity. I would like to present for you the results. So we're comparing the recall at N for 5 different capacity sizes, 1,000 to up to 5,000 tests. In general, since in Israel during April we had many technical problems, we decided to normalize the data and to work in time frames of weeks. So we aggregated the entire testing of the week and the results during this week. And the initial data exploration showed that we had about 5 weeks of data. So we used the first 2 weeks to learn the model and the 3 following weeks to predict. Also, I can show you for the winning strategy. Just to make sure, because we didn't really have that much data, we used bootstrapping to calculate confidence intervals. So as we can see, at 10,000 tests per week, we get a recall of, which is about 2% of the test during that week. We get a recall of 34 positives out of the 34% out of the total positives this week. With 10% of the capacity, we already get 66% of the positive during that week. And if we elevate the capacity to 70% of the capacity, well, we are at 92% of the capacity of that week. So this really enable us to allocating a testing capacity for exploration without harming the recall. So as I said, we can do both ranking and exploration without losing the recall. So what does this framework look like? As I said, we're working in time frames. So every time frame, at every time frame, we are ranking candidates, testing, investing most of the capacity, about 70% of it, for the top ranked candidates, and about 30% of the capacity for exploration. At the end of the time frame, we would evaluate or use the collected data during this time frame and the previous time frames to relearn the ranking model and to evaluate our exploration. If we have areas that were neglected, like cities or demographics, then we can set them as a goal for exploration, for random testing in these areas that were unexplored recently. And as you can see, all the people here, the icon of the little people is where the domain experts are involved. So we are keeping them in the loop, and they're using the system, but they're also driving the system and making it work. So and there is in the initial stage of building the ranking model, which is really using the domain expert knowledge at the beginning, and when we also aim to improve it as we go along. But this ranking model, it can be plug and play, and we can plug any ranking model if a better one is suggested, just like this one here, or recently in Israel, Clalit Healthcare suggested the new ranking model, which sounds really cool. So any ranking model could be applied here to rank the candidates. How do we implement exploration? We can implement exploration in many ways. We can do random testing in cities, regions, or population. We can test the medical staff. We can test the patients from healthy people from infected regions. We can do random tests in supermarket, just like we did in Israel at the beginning of the pandemic. We can test patients with symptoms that doesn't match the current symptoms that we know of. And also, actually, just today, they invented the most genius. Well, they don't call it this way, but I thought it was genius. They tested all the kindergarten teachers. So I think it really is a great survey of the condition in the country. Another important thing is that another important point is that we tried two models in different time frames, and training the two models based on different time frames, and we can see that there are significant differences in their efficacy. So what should suggest that the policy should be updated, and it really supports the need to relearn and re-update the ranking model as we go along. To conclude, I redefine the setting the policy for COVID-19 testing as a sampling problem, and not just a sampling problem with the need to balance between two different goals. The goal of maximizing the detected risk, detecting all the positive cases, with the goal of building a representative sample.